morning, everyone. Welcome to the Mount Sinai Division of Occupational and Environmental Medicine Grand Rounds today. And I will be speaking with Dr. Craig Katz, who is a Clinical Professor of Psychiatry, also Medical Education, System Design, and Global Health. And I'm a professor in the division recently renamed, let me see if I keep track, the Environmental Medicine, and in the Department of Medicine as well, a secondary appointment. And we're going to talk about our experience in the collaboration to meet the physical and mental health needs of the World Trade Center responders here at Mount Sinai. Great.
Good morning. Thanks for having me. Thank you, Dr. Delhose. We've been partnering for a long time, so it's good to be back. I'm going to talk about the mental health side of the World Trade Center program and then turn it over to Dr. Delhose to talk about the medical side or the physical side. I'm going to talk a little bit about the immediate mental health response to 9/11, then the long-term mental health response, both from the perspective of the services and the needs that we saw and see, and then try to draw some implications and some lessons. So the immediate aftermath. So my just by way of my background, I'm a psychiatrist, and I actually had co-started an organization called Disaster Psychiatry Outreach before 9/11 in order to help people, communities deal with the mental health aftermath of disasters. And then 9/11 happened. So we didn't imagine a 9/11. We imagined going off to other people's places and helping them, not our own city. But we wound up working at what was the original Family Assistance Center. I don't know if you were in New York at the time, but this was over on the Lexington Avenue Armory, was quickly converted to an assistance center where because we had been working pre-9/11, we were able to work with the city and have a presence there, which was only for the first, I don't know if it was the first week or two, but it quickly switched over to Pier 94 over on the Hudson, where we were also working. We had a booth, and at the time there were actually, we had the fire and we had wheels, but we actually didn't have smartphones. So, we didn't take any pictures. We also were told not to take pictures. So I actually don't have good photos, but this is a photo I was able to find of what the interior there looked like. And we had our own sort of station there, staffed by psychiatrists in particular, and also helping kids. So we helped adults and kids, people that were coming to the Family Assistance Center well, originally people were coming to try to find their lost loved ones, but when the reality hit, then it turned over more to a service center. So people coming for FEMA benefits, New York City benefits, etc. And we were there providing mental health care alongside of the Red Cross was there also providing physical care to people. And at the early on, this is like the first 2 months or so, we saw. We had quite a few psychiatrists volunteer with us. Before 9/11, we couldn't get anybody to volunteer with us. We saw about 850 patients there with a range of symptoms, like very common symptoms, but insomnia, disengagement, low mood, general anxiety, things that weren't necessarily abnormal, but particular insomnia, right, can be particularly debilitating and uncomfortable. So we treated people with small doses of anti-anxiety or low doses of hypnotic medications that we got as a donation. Some of the folks we saw actually got diagnoses, although we were not there to diagnose people. We were there to kind of care, support, and not rush to diagnose. Actually, it was a little disappointing how many of our psychiatrists actually labeled people as having PTSD when it was way too early to have PTSD, when a lot of the reactions were normal or expectable. So we had to do some re-education. But this is something like acute stress disorder would have been something more typical, which is something that can last for a few days, an adjustment disorder. In any case, that was at the Family Assistance Center. We also actually had psychiatrists down at Ground Zero. I was down there myself, kind of trying to provide support, particularly at some of the canteens and respite centers that were set up for the responders themselves. So we were down there too, practicing a form of psychiatry we'd never been really trained to do, but trying our best to provide some kind of support. some people challenged us as to, did we really have a place down there? Should we just let the workers do their work and not be focusing on their emotions? But we were there nonetheless. But that was the first couple of months or so. But there's plenty of data to show that rescue efforts happen very quickly, right? You need to get in and save people if their lives to be saved. Recovery, rebuilding, is estimated to take about 10 times as long as rescue. And then psychological recovery is thought to have a kind of a potentially open-ended length of time. And so we had to start figuring out, if we wanted to help, besides showing up at ground zero at the Family Assistance Center, how we were going to help over the long term. And so that brings us to the long-term aftermath. And our colleagues in occupational medicine had begun to set up a program to address the physical needs. And the director of the program at the time, Steve Levin, was contacted us in the Department of Psychiatry and said, we're talking to these guys and they're breaking down in tears, and we don't have the capacity, the resources, or the training to really handle all that. Can you help us? And so when the World Trade Center program was set up, at the time, it was and through NIOSH, we partnered with them. And I'll say how we got that going, but this was the first file box that we had for our program. This was in June 2002, when the program first started just as a standalone screening program. I still have this file box in my home, but this is where our very, very first patient files were. That's how small we were at the time. And in order, we had never worked with the Division of Occupational Medicine, so we had to quickly figure out how we were going to work together and figure out how we were going to handle the, 40 or 50 patients that were estimated to be coming in each day. How were we going to, kind of get to them from a mental health perspective? And what we wound up doing is setting up a screening program using these different surveys here to look for people and screen them in while they were waiting in the waiting room for their pulmonary function tests or their lab test, or to see the occupational medicine clinician. Right, so the general health questionnaire is a general mental health distress. The patient health questionnaire got at major depression, panic disorder, generalized anxiety disorder, PTSD checklist. This is an older version, but it does what it says it does. We did look for alcohol, and we did something called the Sheehan Disability Scale, which just looks at disability from symptoms. We obviously want to look at people's distress, but we also want to see how disabling their symptoms were. And we set up a system where, depending upon how they filled out their surveys, they would screen in and see us. If they didn't meet any of the already scientifically validated thresholds on those surveys, we did not see them unless they actually asked to see us, which was at that point a rarity. People weren't coming here to see a mental health professional. They were here because they were worried about their lungs, et cetera. Yellow if they did screen in, and red if they screened in on any of the suicide indicators that was in the patient health questionnaire, and I think in the general health questionnaire. They indicated any kind of suicidality. They came to see us, and they didn't have a choice. We said, you got to see us. I think mostly we were able to get those folks to see us. We had predicted that about 25% of people would screen in. And actually, this is some data from the first 1,100 plus patients that came through the door. Actually, the screening rate came in at more like 50% early on. So we were seeing about half of the folks that were walking in the door we were seeing. And when I say we, it was a team of psychiatrists and social workers who were on site, co-located at what was then called the screening program, to actually go over the surveys with the patients and decide whether the surveys actually reflected something accurate, or did they over detect? And if they did screen for something accurate, we had to get them help. And this is just a graphic depiction through. So this is the first 6 months of the program through like December of 2002. Again, the screening rate was about 50%, so it's actually higher than we predicted at the time. So the challenge was, and I think the occupational medicine program had the same challenge in the beginning as well, is we had funding for screening. We did not have funding for treatment. So it took a little bit of time to actually get that funding. Eventually, and I should say, our original funder was not the government, right? The government was not prepared to pay for mental health staffing. They were going to pay for like a depression screening scale, but that was about it. So we were independently funded by the Robin Hood Foundation, privately. But we only originally asked them for screening funding. We eventually asked them for treatment funding, and they again came through. And then the federal government did provide us with some fundings through the Substance Abuse and Mental Health Service Administration and something called Project Liberty, which is the FEMA crisis counseling program that they roll out whenever there's a federal disaster. And eventually we set up mental health treatment as well. We had a team of social workers and psychiatrists and eventually psychologists providing all sorts of pretty traditional mental health care. Psychotherapy, medication management, eventually down the road. And I have to say, I actually am not part of the program anymore. I sort of ran out of gas a little while ago. But eventually my colleagues added psychoeducation groups because we were looking at a group of patients who really were not seekers of mental health care before, mostly men who are less likely than women to seek out care, and mostly more kind of working class, blue collar, not the usual people that seek us out necessarily. So over time, we've set up education groups for people who we think need mental health care to kind of explain to them how it works and kind of ease them into the care. And of course, case management, which has been a huge part of the program for both sides of the program. Just briefly on the funding, because it was a key part. So the Robin Hood eventually gave us over $6 million. And again, we got some money from FEMA. The complicated thing about FEMA is they don't actually pay for treatment. What they pay for is what they call crisis counseling, which is what they kind of consider normal reactions to an abnormal situation. And so that created a little bit of a complexity in terms of the bookkeeping we did. In other words, we couldn't put down in FEMA documentation that somebody had PTSD, for example, because that's not what FEMA was interested in. So we had to be a little creative, I guess I would say, when we got that funding to make it work. And then the substance abuse, SAMHSA gave us money for a couple of years to provide real treatment, and that's sort of how we put it together. And then along eventually came the Sadroga bill, and I guess presenting this slide today in this political climate is a little more complicated, but nonetheless, eventually the federal government, we didn't, every year we were trying to keep pace with our colleagues in occupational medicine through the private funding and piecemealing it, but eventually when the Sadroga bill came through, mental health was fully under the same umbrella as the occupational medicine program, and it's supposed to be there for a long time, as long as people don't muck around with it in Washington. You all may be familiar with this. I mean, all this data is actually at the NIOSH website. But if you think back to that, we went from that to this. Now, this is not all patients seeing mental health. This is all enrollees in the World Trade Center program across centers. And right, so this is the last data that I could find from March. Online at least, but right, we're looking at like almost approaching 90,000 responders and over 45,000 community members that have been screened in the program and potentially treated. So it's enormous, and this is why we kind of call it the marathon and not just the sprint. And amongst the top 10 certified conditions, right, to be enrolled in the program, 3 of the top 10 are psychiatric, right? So there's PTSD. Accounting amongst the responders, about 10,000 patients enrolled that have PTSD. Anxiety disorder, NOS, which means not otherwise specified, which could mean generalized anxiety disorder, problem with excess worrying, or panic disorder, or like a lot of anxiety problems, like a mix of a lot of different things. And of course, major depression, but PTSD being the leading one. So this is to give you a little bit of a sense of the mental health screening rates over time. For the different conditions that we're looking for. This graph is a little hard to read from a distance, but people have been continuing through, this is data we have from the Data Coordinating Center, at least through 2023, but continue to be screening in for all the problems that we were looking for from the beginning, including alcohol misuse and PTSD, et cetera. But I'll break this down in a little bit better detail. I asked the Data Coordinating Center to look at this data for the last year, and they were able to do it through this past September. So from the basically October 2023 to the end of, to basically this past October 1. 22,000 different patients completed the mental health questionnaire, which is actually not all the patients that came through the door. We captured about 3/4 of them. And now I'm going to show you the rates of the different disorders we're looking at and compare them to what we know from, let's say, community samples. So, right, the DSM-4, right, our screening scales were key to the old DSM. Right now we operate in the DSM-5, but the original scales were key to the DSM-4, which is why we use this. So based on the DSM-4 criteria, about 5% have been screening in the last year for major depression, 10% based on the PHQ-9, which is a screening scale. The screening scale just is a number. It doesn't look at, do you have, it doesn't necessarily, if you go by the criteria, you need 5 out of 9 potential criteria to meet major depression. So there's some difference between these two, because the PHQ-9 just adds a bunch of numbers up. So it's a little blunter, I guess I'd say, than actually looking at the specific criteria. So the DSM-4 one's probably a little bit accurate. And you can actually see, either way, it's actually not that different. It may even be lower than community samples based on this number, this 10.4%, which I think is kind of interesting. But it's actually the only condition amongst all these that kind of comes in comparable to community samples. But I would say the other point about this is, even if it is comparable to community samples, what we've done in this program is created a mental health program for a population that otherwise would not really be getting mental health care for the most part, right? So, we're getting access to mental health care, even if these numbers like, okay, it's just like the community, but this is a community, I believe, that otherwise wouldn't be seeing us if they weren't enrolled in this program. And maybe they wouldn't have had as many problems without the World Trade Center program, but we also picked up a lot of people that had pre-existing problems who, prior to 9/11, and then 9/11 just exacerbated them, which is very typical, right? With trauma, actually with trauma, disasters in particular, it's often more the vulnerabilities that somebody brings to the event than the event itself that leads them to need to see someone like me, actually. So we picked up, I think, a lot of those vulnerabilities. So for generalized anxiety disorder, one of the conditions, right, which is a problem with excess worrying, you could see these rates, depending upon which criteria you use, 5.7, 9.8% in the last year of those patients, compared to 1.8%, so significantly higher than community samples. And that's the trend with all these diagnoses. For panic disorder, 5% compared to maybe about double community rates. And the PTSD, based on criteria from the post-traumatic PTSD symptom checklist, significantly higher than community samples, depending upon which study you read, definitely higher, but comparable to what you see in primary care. If you think of the medical program as a bit of a primary care program, it's sort of similar to that, right? But when seekers of healthcare typically, right, have more psychiatric conditions, even if they're not coming for psychiatry, than people who don't seek out healthcare, right? So this is a significantly higher number, or comparable to other healthcare seekers. And then alcohol use actually looks significantly lower over the last year compared to community numbers. And I don't know how much that jives with what's being seen in the rooms, but the rates are significantly lower, which is reassuring because, right, as you know, you put alcohol together with anything else and it makes anything else worse, right? So given those high rates of PTSD, mixing with alcohol, not a good combination. So on the whole, all these years later, looking at the last year in particular, we see generally higher rates of mental health conditions compared to community samples for most of the conditions. And even with depression, which is so common, we still see a fair amount of, seeing, if you look back, even if it's just 5%, 5% of 22,000 people is a lot of people. Now, these scales may be overreading a little bit. They also may be under-detecting a little bit, which is why these are diagnoses just based on paper and pencil, or so to speak, right? Not on clinical judgment, right? Okay, but on the whole, looking at the last year, or the last year that we looked at, about 30% of all patients screened in on something, right? So the original number we predicted, 25%, is actually tends to actually still be fairly accurate. It came down from that original 50% that we saw in the first 6 months or so, which again was higher than we thought. But actually, if you look at patients who screened in for the first time in the last year, right, who were not certified for a mental health condition before the last year, about 21.8% screened in, right? So we're still picking up what may be, again, this is based on paper and pencil, you need a clinician to confirm these findings, but we're still picking up a lot of new mental health conditions all this time later, right, which is why we call it a marathon, right? I'm always amazed by how much it gets picked up. I'm always amazed how many people, I don't know what the rate is now, but I was amazed when I was in the program, how many people came in for the first time so many years later, right? Now, looking at the treatment that we've been giving, looking at the procedure codes, we found that for people that were already certified for a mental health condition before the last year, who came into the last year having a mental health condition, they were in treatment for almost the last year and came for about 16 visits, right, over the last year, which is about 1 to 2 per month, which depending upon the condition may be enough, maybe not enough, maybe enough for medication management. Psychotherapy, it depends. But they're coming in a lot and taking, and the duration of those visits are almost spanning the entire year, right? So people are needing ongoing care all these years later. Well, this is where I got the data from, but you probably know this better than me. So to move on to sort of some implications, lessons that I've drawn. Firstly, the key thing, and we were just talking about this, by far the most important thing that we did was co-locate with our colleagues in occupational medicine. Like, I had an interest and activity in providing disaster mental health services before 9/11. So this was not something that was new to me. However, like helping people after disaster. However, if we had set up our program as a freestanding program, never would have seen all these guys. There's just no way. So we would have been like Lucy, just waiting for people to show up, right? But because we were co-located right there, we were able to get our business. And I have to say, early on, we didn't even call ourselves mental health professionals. We called ourselves counselors because we were very concerned about the stigma and what it would be like for people. Over time, I think we've earned some trust and credibility, so we don't have to kind of hide who we are anymore. But that's what we had to do early on. But we gained that credibility really by being paired with all of you, rather than going off in a corner on our own, which is how, like the World Health Organization, it's consistent with the standards for how to increase access to mental health care, which is, they say, integrated into primary care. This is a version of that. Some other implications. Well, private funding was definitely key. If the Robin Hood Foundation did not come through, and I still remember getting that first call from them that we got their first grant, I would not be standing here today. I mean, maybe when the Zadroga bill came through, something would have happened, but the whole course of things would have been different. So the federal government was just not ready to step up the way they were for physical health at the time. And I've been consulting in Israel since October 7th, and you see the same thing there. I mean, they're in more disarray than we were after 9/11. But even a place there, which is very used to mental health trauma, the government has not stepped up to kind of fill the gap yet. So our government actually, I think, was somewhat ahead of the curve, at least in setting up this program. Obviously, be prepared for the long term, right? I already kind of made this point. You're all here, we're all here. And definitely to be prepared for like a lot of different needs, right? In other words, giving somebody Prozac is not going to be sufficient, right? If they are out of work, right? For example, or if they have a lung condition, and we've had to address a lot of socioeconomic needs and not just be a psychiatrist. And this program also exemplifies a basic point about disaster mental health, which is you focus on vulnerable populations. This is the idea of a disaster community, which is the community that grows up around a disaster. And at the epicenter, so to speak, are the victims or survivors. Those are the people who are most likely to be affected. But then the service providers, and that's the orange ring, and that's who we serve in this program, right? And so just based on what we call exposure, there close to the ring. And of course, many service providers were next of kin, right? Because so many of the fire and uniform services were lost on 9/11. And of course, the service providers sort of become survivors insofar as they have all the medical conditions too. So these rings kind of collapse together when we look at our population. And well, I can skip this, but this is talking about risk factors for mental health problems. And the first one is the dose of trauma, just the exposure itself, right? But all the other ones many of them are about who they were before, as I said earlier, bullets 2 through 5 or so, or actually all of them really. But these are all things that are so-called modifiable. Now, the prior trauma, prior psych history, what people's lives were like before 9/11 are all factors that fed into the likelihood of needing to see me. But the threshold for coming to our program was the exposure. Almost done. Ideally after disaster, this phrase "build back better." I mean, I think we definitely build back better. I mean, the program we have here is really like a gold standard program for how to treat a disaster-affected population, responders or community members. They have much better services than they did before. Certainly from a mental health perspective, I expect from a physical perspective as well. So we definitely have built back better, and it is really a model. I'll skip some of these other points. Just a few missed chances. I mean, now we have telepsychiatry. Certainly the pandemic helped with that. The current telepsychiatry rate is about 11 to 12% of patients are seen through telepsych. But early on, I had wanted, before telepsychiatry even existed, way before Zoom when we first started, I had wished we'd had a mobile program, because I was most worried about the people who weren't coming in. And we looked into buying like a van and going to people's homes, but we never got the funding. I also wish we had done some kind of occupational rehab. I think there is now, I think, an occupational therapist, I think, over in the mental health program. But I wish we had done that from the beginning and have a much more robust program that wasn't just focused on psychotherapy and meds, but on trying to give people back a career of some sort, some sense of meaning, and of course, income. I think we would have actually reduced the number of patients we have who are mental health patients if we had done something like that. And I also wish we'd focused more on resilience. These are Dr. Charney, our dean's resilience factors that he's written about quite a bit. We were focused on problems. I, over time, have come to appreciate how resilient people are. And certainly, even if you have PTSD or even if you've got a lung problem or a prostate problem, whatever, from 9/11, our patients are tough. We are human beings, are built to be adaptable. And I wish we had set up something more about promoting resilience, which is something we've done during the pandemic for our healthcare workers. We set up resilience workshops through the Center for Stress, Resilience, and Personal Growth. I wish we had done something in the program itself. Okay, that's my presentation. Thank you very much. I'll turn it over to Dr. Delahose.
Okay. Thank you. So moving right on. So just to follow up on what Dr. Katz has mentioned, how we had that task of figuring out, what the care needs of this cohort were, and how we went from the sprint to the marathon. So these are my disclosures because I do a bunch of research. They are not related to this, and certainly are not the views of NIOSH. There's always that disclaimer. And I just have these. I try to select a few personal views of what my work with the cohort has been for a little bit over 20 years. And with a little bit of a focus, given my specialty on chronic lower airway diseases. And as I mentioned, the size of this cohort continues to surprise us. This is a lower estimate. We thought it was about 50,000 rescue and recovery. This is obviously more than that. And an important thing from the point of physical health and occupational medicine is that essentially every opportunity to characterize what the exposures were was missed. So we are, they always ask us, like, what was in it? And in fact, that's the first question, and it's exactly the one that we are unable to reply or answer satisfactorily. So a number of adverse health effects, including lower airway diseases, have been described. And but one of the challenges that we had as physical health clinicians was to really try to characterize them, because they tended to be heterogeneous, and sometimes they were difficult to classify. So I always put this picture because I say, this is really how it felt in January of 2003 when I started. It was this multi-symptomatic cohort, and we still see a little bit of that. And we had to quickly figure out they gave me a month to put together the protocols for the treatment program, because in the screening side, people were definitely very generous with their symptoms, and we have to try to put some order to what that was. So I had to quickly adapt some previously published protocols to really try to come up with a way to work things out and try to figure out what these patients had. And so that was for lower airway disease. This was for gastroesophageal reflux disease. This was for chronic rhinosinusitis, pharyngitis, and laryngitis, the evaluation of the whole upper airway. And essentially, after a few years, we came up with a classification of the main adverse health effects of this population, including mental health, of course, is there with the three major categories that our colleagues, co-located colleagues, were sharing with us: chronic PTSD, major depression, agoraphobia, panic disorder. But we have the upper airway disease, gastroesophageal, lower airway disease, and a number of musculoskeletal conditions at the end. So comorbidity was the name of the game. As you see, there are very high percentages, and at the center, the comorbidity of gastroesophageal reflux, lower airway, and upper airway actually was the most typical presentation at the beginning of the program, making the care fairly challenging. So these lower airway diseases were, as I said, heterogeneous, and we classified them initially. Not all of them were asthma, but some of them had a picture of a chronic nonspecific bronchitis or bronchiolitis, or in some cases, very few, there was some pre-existing obstructive lung disease that seemed to have been work exacerbated. And the most common abnormality in the basic lung function testing that we did, the spirometry, was a reduced forced vital capacity, or what I'll call from here on low FVC. So as you can see, if the spirometry was abnormal, the most frequent impairment was by far a low FVC in 30% of these patients that I initially published many years ago. So in terms of a brief review, Dr. Katz mentioned the worker and volunteer medical and monitoring program. Is a screening and monitoring program. It started with Drs. Herbert and Levine back in 2002, and eventually became funded by CDC, NIOSH, but the screening really began in 2002, and the monitoring, the health surveillance, continued the program with periodic visits every 12 to 18 months. You all know many of these details about the advisory committees that provide guidance to how the program is conducted. And what I came to organize was the treatment program, again, the same co-directors, and we started in January of 2003, just following on the heels of the screening program. And as was the situation with the mental health side, we depended on philanthropic funding with the foundations giving us funding pretty much from 2003 until late 2006. And after 2006, it became funded by the federal government. Eventually, with this Zadroga Act, for a very long term. So, as was already mentioned, this is just a depiction of how the two departments collaborated, psychiatry and what was called at that time community and preventive medicine. That's where the Selico Occupational Clinic was based. And essentially, initially, both programs created a screening program. And then in about 6 months, 7 months, something like that, the treatment program started on both sides when funding kind of tended to merge all of these programs into a single one, but the different sections of the program are still recognizable given their functions in surveillance and screening and in treatment, individualized treatment. So this audience is familiar with the process, with the questionnaires, physical exams, spirometry, chest radiograph, routine laboratory tests, and the follow-up visits. As was already mentioned, we are not primary care doctors, but we really work with those doctors in the community, be there in primary care or specialized, to provide care for these individuals. The background of the different clinicians that have worked in the program is diverse, and we built essentially a network of consultants in the different specialties that were relevant to the disorders that I listed before. One quick mention, the third element, we were co-located, but there was a third element, and unfortunately it's not very as visible as it was at the beginning, was the social work presence. They were under the treatment program, and they, in the first couple of years, they would see upwards of 70% of the population in the treatment program. This was a very high percentage, and at that time there was a strong push to try to get workers' compensation claims. This was before the Affordable Care Act, so there was a high proportion of individuals without insurance to try to provide access to health care. They help us identify and coordinate care with our mental health side of the program. And there were a variety of programs that were made available at that time that they would provide too long a list of benefits that we would try to refer them out for our patients so that they would benefit from them, and also access to disability benefits. We try to work with the workers' compensation vocational rehabilitation unit in trying to provide some services, and also through the state vocational service. The success was mitigated, I would say, but was not for lack of trying. And they also help with a variety of other issues that these patients had in housing, substance abuse, domestic violence, even some immigration legal services, etc. So essentially, the program, the health program was established with the Zadroga Act, and it does cover research, and it does cover the data centers and the clinical centers of excellence, and a network throughout the United States, and operates on covering a number of diagnoses that are presumptively related to the World Trade Center exposures. So I will just switch a moment, because one of the challenges that I had as a pulmonologist, as a clinician, was how to find objective evidence of what was going on from the point of view, respiratory point of view, because low FVC is a very non-specific pattern that can be related to things like poor performance of spirometry all the way to obesity. So it was, the challenge was that there was a lot of doubt as to what the significance was. So right at the beginning, I tried to work with the radiology department because I thought that one of the explanations for the low FVC was a lot of air trapping related to a small or distal airway disease. And this is a small airway. The conformation that it has, a very thin wall, no cartilage, of course, and this is when it is inflamed. And this is actually from the same patient. The disease is usually focal. So it's in some area, it's patchy. So you could use a CAT scan to really try to put it in evidence, and I asked the radiologist to come up with some semi-quantitative scale to really try to look at that. And we were doing CAT scans at the end of expiration and at the end of inspiration, which is the conventional way of doing it. At the end of exhalation also added some views. And if that is the normal view, there's a very slight homogeneous change in intensity. What we were seeing in many of our patients was this checkerboard pattern on the end expiratory CT scan, where you see that the density increases more in some areas, but not in others. The areas where it look dark here is areas of the lung where air is being trapped behind an obstructive small airway like the one that I showed before. So we moved on eventually to a more comprehensive system, and again, looking for ways to objectivize these findings. And we had the collaboration from an international group that gave us the reference films and the training on the use of the International Classification of Occupational and Environmental Respiratory Diseases, ERT. And the first study that we published, we have close to 1,500 subjects with chest CT scans. And we could see that there were substantial proportion of individuals with these abnormalities, including the end expiratory air trapping that I mentioned before, and linear opacities, rounded opacities. So we could see also that about pleural abnormalities consistent with asbestos-related pleural disease were present in about 1 in 5 of these 1,500 subjects. But because of the dates of the CT scans, we actually, and given the latency and the occupational groups that were affected, it seemed clear that it was mostly pre-World Trade Center occupational exposure to asbestos, the one that was seemed to, it was most likely responsible for those changes. And we, of course, this was not unexpected. The group of workers that were laborers or asbestos handlers or building cleaners tended to have more of those abnormalities. So we moved on to more sophisticated ways to quantitate the abnormalities in the lung, and that's what we are currently using, quantitative chest CT scan. Essentially, these visual engineers, this was something that started around 2006, and has progressed quite a bit. So these visual analysis engineers essentially can partition the different structures of the lung and segment them, and then do measurements, quantitative analysis, measuring different structures of the chest. Essentially, every structure of the chest, if there is a difference in density, they can partition it and measure it, and there are a number of parameters that can be derived from that. So we work with 2 engineers, Dr. San Jose Stepper from Harvard, and Dr. Rees from Cornell. And between the two of them, they essentially measure a variety of structures, pleural thickening, cardiovascular, measure lung volume, emphysema, airway parameters. And one of them that we were particularly interested was measuring the inflammation of the bronchial wall. If this is a bronchus, it's cut, cross-sectionally, the thickness of the wall, increasing thickness of the wall reflects inflammation. So like you can see here, and the change can be seen, is kind of subtle. A very experienced chest radiologist can actually notice that difference, but of course an engineer can give measurements that are much more precise and that we can use in research. So that's what we call wall area percent, the percent of the cross-section of the airway that is occupied by the wall of the bronchial tube. And we could see that it was correlated with accelerated lung function decline on surveillance, so that people who decline faster in their lung function had thicker bronchial walls. So that, and we published that. We also identified a group of individuals that seem to gain lung function, and that's something that you do not expect in individuals that are in their 40s and 50s. Peak lung function is achieved by age 25 to 30. So humans of this age usually, essentially, are not expected at all to gain lung function. And we think that these gainers represent individuals who have a very precipitous loss of lung function right after 9/11. And that we're still working on that category, subgroup of people. So this was the model where, again, the main predictor, wall area percent, had a 47% odds of being increased in individuals who had an accelerated decline in their expiratory flow. So that was the first of those. We also noticed that obesity and weight gain, which are highly prevalent in the World Trade Center occupational cohorts, had a correlation. And in fact, we studied that using a control group from a federal study, COPD gene, that had World Trade Center unexposed and also asymptomatic subjects. And we were able to do a comparison. The blue line is the COPD gene asymptomatic controls. And you can see that there's not much of an association, essentially no association, between body mass index and wall area percent. But in the World Trade Center cohort, is this red line here, there is a very clear correlation. And when we did a stratified analysis, notice that those individuals who had is shown better here, that had lower airway disease, had that correlation that was significant in those who had already inflammatory disease. So this is the World Trade Center with lower airway disease subgroup. And so that BMI was significantly associated with wall area percent in the World Trade Center workers with lower airway disease, but not in normal control subjects. So this is what the analysis that we did after a number of years. This is already 2021, when we could use data from, at that point, for about 15 years of the screening and monitoring. And we could see that the majority of the group is on this green line trajectory, which is, the expected age-related decline in expiratory flow. But we could identify a group that was losing, and this is what I referred before as accelerated expiratory flow decline. And here is the other, as I said, more controversial group of people who are gaining lung function. There's a lot of skepticism in the pulmonary community about the real existence of this, but we think we see it. And we continue investigation of this group in particular. So I will skip this part just so in the interest of time. So just to say that in the individuals with low FVC, we definitely demonstrated that they had increased wall area percent and airway wall inflammation. That was what the previous one. And then we did classic association studies where we tried to see if the this parametric diagnosis of COPD or asthma and COPD overlap were related to the main indicator that we have or higher exposure at the World Trade Center site, which was arrival within the first 48 hours. And we did a case control design, nested within the cohort, and essentially identified about 500 cases of COPD in 18,000 workers, and about half is split between COPD without asthma and COPD with asthma, with the case definition that we had here, mostly moderate and mild COPD. And we could see that there was an increase, it's a modest increase in the odds, adjusted odds of COPD in this cohort, and you can see here the margins are wide, but they're still statistically significant, and more so for those who had asthma features, which in this case was defined as a very large bronchodilator response. So, and we could see here the trajectories that in terms of loss of lung function, those individuals with no COPD had a decline in FEV1 of about 35 mLs per year, which is about what people in the general population, non-healthy individuals, would lose. COPD, of course, they are losing about double of that rate. And those who have asthma and COPD overlap are kind of intermediate between the two categories. So we continue these studies with the trajectories because, as I said, apparently at the beginning you see a decline that on the average seems to be what you expect, but you have these subgroups that have divergent trajectories that deserve a lot of attention in these contexts. So we also use a lot of the data that we had available and did this classic cluster analysis to really try to come up with some characterization about the different groups. I won't get into detail into that. In the left-hand side, these individuals have characteristics classic of COPD in terms of their findings, their lung capacity, their inflammatory changes, and these are relatively healthy individuals here. Our low FVC group is subdivided into one that was relatively asymptomatic and another one that was quite symptomatic. And then we have a number of a very interesting group of non-susceptible, what we call, heavy smokers, but mostly with preserved lung function. That, but in some of the quantitative CT markers, they were showing, and this is what this is highlighted here, a lot of inflammation in these smaller airways. I won't mention, we did have some studies try to do, this is another approach that you can use whenever you have lung available, of course, to do mineral analysis, and we could see dust particles in the lungs, but it is difficult to quantitate them. So the studies end up being qualitative, and so the interpretation becomes difficult. And we are also examining, how these patterns of abnormality, normality or abnormality, make transitions to each other and what factors underlie that. Just tying in with our mental health colleagues, we published in 2016 a study of the association between probable PTSD and bronchodilator response. And through different sensitivity analysis, we could see that the association persisted even after we removed smokers, people without any pre-existing asthma. The adjusted association persisted, and it was also increased in those individuals who have the more chronic forms of probable post-traumatic stress disorder, which is this gradient that is shown here in this part of the graph, of the table. So again, going back, this is how it looked at the beginning, and I never forget that. These colorful multi-symptom picture that these workers had, and basically in terms of the this cohort, we had this convergence of occupational exposure, tobacco smoking, highly prevalent physical and psychological comorbidities, and highly prevalent overweight and obesity. And we have to track, all of those factors in as determinants of the respiratory health of this population. So there are a number of biases, confounding, time-varying variables. We are using comparisons of more versus less WTC exposed when the exposure were really not measured. We are using very crude indicators, but we believe that there are quite a bit that can be lessons that can be learned from the study of these cohorts. And we are also making a contribution to the utilization of chest CT scan in occupational respiratory surveillance in particular. So we think that it can complement the screening efforts of exposed populations, and hopefully from these studies, methodology will emerge that will give some guidance as to how best to use it. All of that work it took a village. A lot of people that collaborated over the years with me in this, developing this, and of course the staff of the clinical center and the data center that produce essentially all the data that I am showing you. So with that, I'll open for questions.